You are grieving and your heart is broken, but you are not broken. You do not need to be fixed. I'm Holly Gainsboro. Welcome to Creating Space for Grief and Hope. Hey everybody, welcome to Creating Space for Grief and Hope. Super excited to be on YouTube again. This is very wonderful for us. This is the second episode on YouTube, and I am honored to have an incredible woman here. I'm going to share a little bit about her with you. Her name is Dr. Annick Desjardins, and I say it correctly because I know her and I have known her for quite some time. So before I read her impressive bio, and you may see me look down every now and then, so just to let you know, I want to make sure I maintain the integrity of this woman and get everything right with her bio. So Annick and I met many years ago. I'm not sure if she even remembers. So Stephen, as many of you know, my late husband, Stephen Gainsboro, was diagnosed with glioblastoma February 12, 2009. It is mind-boggling to me that it's been 17 and a half years almost since his diagnosis. And he was treated at Duke. Now, his main neuro-onc was Dave Reardon, who Annick knows well. But I was very blessed, Steve and I were very blessed that we got to meet with Dr. Desjardins a few times on the times that Dave wasn't available. And I will tell you, the whole staff at Duke the Preston Tisch Center is phenomenal. There are other wonderful brain tumor centers in our country, and this is one of the top ones. So that's how we met. Then, a couple of years ago, we had the pleasure of meeting up again at the Glioblastoma Summit in Miami, which many of you who have been listening have heard me talk about. I've had Amber on here, so you know what I'm talking about. And we really hit it off on such a different level, which was super exciting for me, right? To meet somebody and talk to her and talk to Annick, almost as what, because when we were going for treatment, it's like, the doctors are here and we're kind of like, we're on the same level, but it's just a different experience, when someone's caring for your partner. So we really got to talking the past couple of years, and she's just, I got to tell you guys, she's the real deal. There's no ego. She is authentic. She is caring. She is brilliant. And she is completely committed to her patients and the work she does in neuro-oncology, specifically brain tumors. So that's my feeling about Annick and why I'm so happy to have her here. I was so excited when she said yes, she would come on. So let me tell you about her medical background before we get into personal stuff. And again, I'm going to look down and read this. Dr. Desjardins completed her residency in adult neurology at the Université de Sherbrooke, hopefully I'm saying that correctly, Quebec, Canada, followed by a fellowship in neuro-oncology at the Preston Tisch Brain Tumor Center at Duke, which she afterward joined as faculty in 2005. That was a long time ago. She is professor in the departments of neurosurgery and neurology at Duke, director of clinical research at the Preston Tisch Brain Tumor Center at Duke, clinical trials core co-director for the Duke Brain Tumor SPORE and PO1 grants, co-director for the Biostatistical and Clinical Hub of the McCain Bay Glioblastoma Consortium, and co-chair on the Duke Cancer Institute Protocol Review and Monitoring Committee. Since 2026, she is co-chair of the Society of Neuro-Oncology Membership Committee, also known as SNO. She is a fellow of the Royal College of Physicians at Canada in adult neurology and certified in neuro-oncology by the United Council for Neurologic Subspecialties. Dr. Desjardins has been the principal investigator on over 45 therapeutic trials in neuro-oncology, has led international multi-center trials. She has over 135 peer-reviewed publications in 8 chapters. And that's just a little bit of the bio she has. But if I went into the whole bio, we'd have very little time to actually chat. So if you want to learn more about her, you can Google her and you will find her amazing credentials and the things that she is doing on behalf of the brain tumor community. So welcome, my friend, to Creating Space for Grief and Hope. Appreciate you being here.
Oh, thank you, Holly. Thank you so much for having me. I'm really excited to be here. And thank you for all the nice things you said. Thank you.
Well, it's true. And it seems so fitting to have you on in July.
Yeah.
Because Glioblastoma Awareness Day is next Wednesday, 1 week from yesterday, July 15th.
Yeah.
And with that, Glioblastoma Awareness Day was a long time coming, and it's been happening for a few years now, Brain Tumor Awareness Month in May. But for those of you who are part of the brain tumor world, and not all my listeners and viewers are, brain tumors are I feel like they're just coming into the forefront. It's been a long time, like I said, coming, for different states to recognize Brain Tumor Awareness Month and for the country to recognize and to make these awareness days and awareness months really, visible to the greater public, because some people just don't get it. They don't understand it. So this is, July 15th is a very important day. I'll be posting a lot about it for those of you who follow me on social media. All right. So talked all about your medical background. So girl, let's get personal. Okay. Very different interview you're used to having and conversation, and it's more conversational. I know most people you talk to on podcasts want to know what's the latest research, what are the statistics, what's happening, why isn't there a cure, all of these things. And we all want to know that, but you know what? There's more to Annick Desjardins than being in a lab and being in an exam room. So what drew you to do this work, right? Because we're all pulled to do something. The reason I do what I do is because of my experience with Stephen. What was the pull for you to study neurology and then get into neuro-oncology?
No, I mean, it's a great question, and it's really, I also have a hard time understanding it, to be honest with you. So my father is a businessman. We had our own business, and when I was little, my dad worked, many, many hours a day. But where he really spent time with his daughters, so we're two, I have a sister, so we're two girls, and the way our dad spent time with us was really doing volunteer work. And volunteer work for the Canadian Cancer Society, right? I'm from Canada. And so we were doing volunteer work. So since I'm like 5 years old, I've been cleaning daffodils, right? Before the daffodils, I've been, right, like going door to door to raise money. So I spent a lot of my time with my father, in fact, in the Canadian Cancer Society office, being surrounded by information about cancer survivor and, caregiver support. And so I knew I wanted to go in medicine. I've been telling people since I'm 10 years old. I still remember because that I would be an oncologist someday. And people will say, what are you talking about? What is an oncologist, right? Because you have this 10-year-old that says I'll be an oncologist. And I'll say yes, because, right, the patients need us, the family need us. So I went into medical school. I'm the only one in my family who's in medical field. Everybody else is in business, construction. I'm really the only one teaching. I'm the only one in medicine as a physician. But so I started medical school, clear I was going in oncology. And then in medical school, I fell completely in love with the brain. I thought neurology was so cool. No one understood the brain. No one understood what, how we move, how you would think, how we speak. And so I fell in love with neurology. And then at some point, I just brought the two together because as a neurology first year, I mean, I was an intern, so finished medical school, start my internship as, and as an ND. And one of my first patients was this young woman who got diagnosed with a brain tumor. And I realized that there was a need for neuro-oncology, so I could combine my two passions of the brain and oncology care support. Wow. So I don't know how a 10-year-old know other than, yes, my father.
You know what? You don't need to understand why. You just know what the why is. You don't always have to dig deeper and say, I wonder what that's about. I am curious, what was it about for your father? Of all the things to volunteer for, what was it for him that he brought you into this cancer society?
Yeah. Yeah, so the side of my father, the side of my father's family has very, very high rate of cancer. So they have had, right, so they have the BRCA gene, so that we know increase the risk of breast cancer. So most of the women on my dad's side of the family have had breast cancer surgery, lymphoma. My grandmother, his mother, died of colon cancer. So my father, at 21 years old, became the guardian of a 17-year-old and a 14-year-old when their mother died, and their father had died years prior from a farming accident. So really young, my father became the guardian of his sisters due to cancer. And so that's why it has always been important for us.
Well, that makes a lot of sense then. When we take our pain and put it to purpose in some way.
Yes.
And what a gift he gave you
Yes.
to introduce you to this field, and you became a gift to all of us.
Yes.
So is your father still alive?
Oh, yes, he's still alive. Now, he is himself a cancer survivor, right? I think that the main reason why he is a cancer survivor is because he knew of his family history and he was so, I would say, demanding, which you have the right to be as a patient, but so demanding on his doctors of saying, I need to be imaged, I need to be scanned, there's something wrong. And because of that, we were lucky that we caught his cancer very, very early. And he's now in remission. He has 9-year remission from a cholangiocarcinoma, which is a very aggressive cancer that normally are caught way too late. So yes, he's alive. I will tell you one story about my dad. One thing I didn't tell you. So my father, I think I've pretty been a good child, right? So I've had, of course, little teenage things, but not that much. But overall, I've been a great child for my parents. The only time my father really, really got upset with me was the day I told him I was going in neurology. And he
Really?
told me, yeah,
What was that about?
because he told me, he said, you are not a neurologist, you are an oncologist. Like the only time that he was like really upset. And he was like, no, I know what I'm doing. There is such thing as neuro-oncology, and that's what I'll do. Right. But that's the only time that my father, like, I moved to another country. Like, I've lived away from them, right, for now 23 years, right? It is fine with that. But really was that when I went into neurology. And so now he's really excited, though, that, I'm doing both neuro-oncology.
That's really funny. Well, you know what? He knew what he wanted for you. He knew what was important to him.
Exactly.
That's a great story. What is your dad's name, if you don't mind me asking?
Edmond. So it's
I always like to ask people's names if we're talking
yes.
about family members. So thank you for sharing that. So, I talk a lot about, you and I talked about this, about forgotten grievers. Sometimes it's caregivers, siblings, and sometimes the forgotten grievers. But I think one of the biggest misconceptions is that the medical community, physicians, nurse practitioners, PAs, nurses, clinical social workers, I mean, we can go on and on, researchers, front desk staff, that they all have this armor around them, right? And they don't feel the emotions and the impact of their patients, whether it's progression or whatever it is, and the grief. And we know for a fact that that is not correct. And so the medical community are truly forgotten grievers and think that you brush things off, it's fine, we don't feel anything, we've got to just go in and do our job, and we're just going to be clinical, and that's that, in this sort of sterile environment. So the brain tumor world is not an easy world to work in. And there must be some things that come up for you emotionally with your patients. Are you comfortable? Is that okay? Are you comfortable talking about that?
No, I'm comfortable talking about it. And as you said, Holly, I think that one of the difficult thing about why it's hard to talk about it is the fact that often we don't feel like we can show it, right? How hard it is. I think that I'm thinking, right, we were hearing that, about, I hear a lot, right, about, right, this doctor is so cold. And I think a lot of those people, if I talk with them, like those physicians, the patients will tell me this person is so cold. So often it's because, right, it's the way of protecting themselves. But the answer is that we feel deeply, right? Right? We feel deeply the loss. It is, I know, I mean, I say we, but I and our team, right, at Duke, all of our first, I'll go back to the first thing you said, which is brain tumor is difficult, right? Like it's such a difficult because you're dealing with cancer, right? That to this day, cancer, we don't have cure ready for any of the cancer. We can control cancer, but we don't have cure. And we have lots of cancer that we have been lucky. I've had a lot of discovery over the years. But even pancreatic cancer, there is data coming out that, they're seeing better and better result. Brain tumor, right? I've been at Duke for 23 years. I was already as a neurology resident working with a neuro-oncologist back in Canada for 3 years, running his lab, running his, in fact, his clinic while he was in the operating room. So I've been doing brain cancer research now for 26 years. And we're basically at the same spot we were, meaning that we haven't improved really the survival of the patient. We don't have a treatment that is the silver bullet, right? But I would say that from my standpoint, what has changed is what has improved is how we care for our patient, right? The resources, right? Saying the importance you mentioned, right? The social workers, right? The support staff, the APPs, so the nurse practitioner, physician assistant. So I think our nurses give a better support to our patient. We have better understanding of how can we help them with the fatigue, how we can help them with the memory changes, how can we better control seizure, or seizure medication have better side effect. But I think that all of that to say is, so it's really hard because I'm rambling right now, sorry.
No, you're not. It's great.
But so we're dealing with the cancer, right? That is very poor treatment. And we also dealing with your brain. And you're losing who you are. You're losing your autonomy, right? And this grief of, right? So I think that for me, the hardest is that the grief of, I might not have known your loved one, right? I might not have known your husband, right? Who he was before his diagnosis. But I knew him and each one of my patients, like from the day he entered my life. And as sad as it is for a family member or a loved one to see patients losing their autonomy, losing their function, I have the same grief, right? I look at my patients, right? Like this week, for example, I saw patients in clinic and I remember who they were 10 years ago when we first met versus today. And grieving this autonomy, the memory changes, the loss in function. It's really, really hard. So and in grieving the fact that I still don't have a better tool, right? To help the patient and to help the family. So that is a big grief of me. And all I would say anyone who does research in brain cancer, right, is really thinking about the fact we have been doing this for a long time. And a family member the other time told me, don't you know better by now? Right? I wish I did. Right? What I do know better by now, though, is how to listen. Right? How to support what I can support. The headache, the memory, the seizures. Right? And then, so that's one answer. The last answer is really also because it's so hard to take care of those patients. Everybody that does, any medical professional who cares for brain tumor patient, you need to be really special, right? And really caring.
Yeah.
Because if you're not, that job is really hard and you won't be able to help patients. So anyway, I could talk more, but Ollie, I'll let you ask me this question.
Great. Thank you. Well, I want to piggyback on that. So, I have a list of questions, but sometimes the conversation goes the way it goes, which I always love. So you said something that you listen better. When you first started many years ago, 20-something years ago, what do you see in your own evolution, beginning as a neuro-onc and now? And there's got to be changes, like when you say that you listen better, what do you notice about yourself?
Yeah.
with that coat on when you walk into that, exam room.
Exactly. So I don't know if it's the right term to say it, but how I explain it. So we train, right, fellows. So we train the next generation, right, of neuro-oncologists. And why I tell my fellows is I'm now a master in failure, right? So when you start as a brand new doctor, brand new graduate, right, you know what is in the book and what you're supposed to do, and you're so afraid of making a mistake and not following the recipe in the book and not ordering all the tests that you were told to order. Longer you're in the field, the experience is really being medicine is not a science. Medicine is an art. My patient didn't read the books, right? So I think that the books, the literature gives us a pattern, a direction, right? But each patient is their own person. And I think what has changed with me is now I have more confidence in myself and recognizing the patterns, right? Recognizing what is happening, not being so afraid that it doesn't follow the list of symptoms, the description that was in the medical book or in the article, but being able to recognize the pattern enough and feel that with what is happening right now, I have something that can help you. So it's mostly confidence in myself, right? That I can recognize the patterns and help.
That's great. Yeah, I love that you call it an art. I've never thought of it that way. That's a really beautiful way to put it. You talk about your fellows that come in, residencies and all that. And you don't learn in medical school compassion. That's not part of your course of study. And, I once spoke at Charleston, Benham, USC. I spoke to PA students many years ago when I first got into the grief field after Stephen had died, and talked about the caregiver and patient experience, and talked about the emotions that come with that and how can you be present and bear witness. And I had somebody say, and I think they were all studying the brain tumor, the neurology, neuro-onc piece. And I had a student say to me, and so young, and they're like early 20s, so young, babies. And someone said, well, if you know the outcome isn't good, what are you supposed to do? And so that's where the compassion piece comes in. And we're going to jump into that. When and how, and you probably have always had this because I sense this is just a part of your makeup, is that compassion that you have for probably most people, everybody. How were you able to, weave that into your practice? Because that's an art. Because again, none of you have learned this. Nobody sits down and says, okay, we're going to do a class today on bedside manner, right? On compassion, on holding space. But not just for the patient, because you did talk about, the patient watching your patients decline, which is what happens with a brain tumor, and certainly what happens with glioblastoma, or astrocytomas, all of that, and they're renaming all of this these days. But there's also a care partner that comes in with them. Whether it's a spouse, a parent, a friend, a sibling, whomever joins them. And so is also recognizing their pain. And that's a lot. You got to bear witness for your patient and really make sure you're taking care of your patient. But also you want to make sure the caregiver feels like they're being seen and recognized. And they can be the demanded one. They can be the one that's saying, I don't understand why you don't have a cure at this point. This is ridiculous. I hear this all the time in my work. All the time. So it's a long-winded question, but it's coming back to this compassion piece. And where did you learn how to be able to bear witness to where people are and that they felt seen, and not just the art of the science part of it, and putting the puzzle pieces together, but also the emotional piece of it.
Yeah. No, it's a great question. I think, right? So my medical school, I will be honest, was really good about that. Really good. in the fact that the learning was a little different in most medical school, where we really didn't have a lot of big lecture all like, so we were 150 in my year, right, in my class. We really didn't have, we have very few classes where we are all together in the big lecture hall. Most of them we were meeting we were doing like small case discussion. So on the Monday we would arrive, they will give us a vignette, right? Even from first year medical student, they will give us a vignette and describe a patient. And then we will have to go research, right, in the books. What could that be? The patient is having strange sensation and is seeing flashing lights and is starting to have headache. And then you have to go read in the books and figuring out, oh, maybe he's having seizure and what could trigger seizure. And so on Wednesday, we will all meet and discuss the case. So the way I learned in medical school was case-based training, which really helped. The other thing about my medical school that was really, really cool is what they did. So there was a movie that I'd done years ago where there was this physician who wasn't nice and got sick and had very bad medical care. And when he went back to teach, he forced his medical student to have medical procedure. And so my medical school did something very similar, where they force all the medical students, all of us, to spend an 8-hour shift on a stretcher in the emergency room, in the stretcher in the hallway, in a hospital gown, with a fake IV typed to our arm. And our homework was that no one will look at us, no one would talk to us, none of the doctors or nurses in the emergency room were allowed to acknowledge us, but we just had to observe what was happening in the emergency room. And so we all spent 8 hours in a nightgown with an IV where we could not move, couldn't go easily to the bathroom. So I think that with those things, learning by vignette, having to spend time in the emergency room, seeing a little bit, even if it was a short glimpse, the patient experience brought a lot. And then after that, right, with medical school, there is so many specialty in medicine, right? There is, right, you can become a radiologist who is in the dark room looking at images, right, of X-rays and MRI results. You can be a pathologist. You can be a surgeon who does procedures, right? And you can be, and I think that to go in oncology, right, people that do go there, yes, have this, I think, as you said, innate compassion. Otherwise, you're not happy, right? And then after that, with this innate ability to listen to people, innate ability to be able to slow down, and then after that, learning the confidence of, okay, I am able to listen. I'm able to empathize to the patient. I'm able to find also a language to explain what is happening in terms that they understand, right? That's also a skill to figure out how to explain it and connect with them, and so they understand and just not the medical jargon. And I think that's how, from my standpoint, right, I felt that you become a successful neuro-oncologist, and that's why I'm trying to bring to our team, right, our fellows, our nurse practitioners, our physician assistants, our nurses, right, of just take the time, sit, give people the space.
Thank you for that. What a brilliant thing for your medical school to do.
It was a beautiful experience. Agree.
Yeah. I mean, that's just brilliant. And maybe other medical schools do that. I think back, I'm older than you. I think back for my generation, I don't think that happened. I think that there were way more egos for my generation of doctors when I was a kid or even a young adult. I think that has definitely, I've seen a shift in that. And I mean, I think about Alan Friedman, who was Stephen's surgeon.
Yeah.
No, like in my opinion, no ego. From my experience, I don't know your experience on the medical side of it, but as the, care partner to my husband, I didn't see that, that he saw us as individuals. We're all humans, and so I definitely see that sometimes, with many doctors. Definitely see it with you. So thank you for sharing it. Thank you for sharing that experience that you had as a medical student, because that's really fascinating. I think it's great for other people to hear that.
Yeah.
Yeah, that you did that. So at Duke, and I remember walking in there, and it's a long story how I got to Duke, how I got Stephen to Duke, but I did, and it was wonderful, and thank goodness for that. As soon as we walked in, we saw that sign. At Duke, there is hope.
Yeah.
And there was also a plaque that said, a positive attitude is a powerful force. Yeah, it's down. And that's way before the brain tumor center is that you're in now. And we went, it was a very small area, and we went down to a basement somewhere to talk to child life specialists on behalf of our children and the nursing staff, whatever. I can't, it's funny, I remember it, but I don't remember it fully because it was such a long, we're talking almost 17 and a half years ago. But I remember those two signs, and I know I bought Stephen, he wanted the sweatshirt. I think I still have it. I've never worn it. At Duke, there is hope. Preston Robert Tisch Brain Tumor Center. And that hope for us was really important. Not everybody feels that way. Dave Reardon gave us hope. We wanted the hope. We wanted that hope. And I will share a quick story with you about an experience we had. So we were living in Charlotte, North Carolina. And so we were going back and forth, 2 hours, 20 minutes, door to door, cuddled to the metal. And so our local, our local oncologist at the time was Wendy Brick, who has since retired. I mean, many, many years ago, I guess she retired, but she was our local oncologist. And then Stephen had a radiation oncologist. I'm not going to share his name. He was great. But the first time we met him was just coming off of surgery, taking those few weeks he's supposed to take before you start radiation, going to have his mask fit and all the things. And he met with us, and he looked at Stephen, and he said something that Duke would never, ever say. The odds are not in your favor. And that was really deflating for Stephen, right? Because he's hearing now from his neuro-oncologist and his neurosurgeon at Duke, there was hope and everybody there. And then he's got this very smart doctor who says that the odds are not in your favor. So now I'm really pissed off. And I'm emailing Duke, and I'm emailing, Wendy Brick, and I'm like, this is not how we want to live our lives. This is not what we're going to do. This is not who we are. And so the next time I brought him in, and this man was very, very, very tall, and you've met me, and like you, I'm not very tall. So I stood up, and you can see me with my neck up, everybody. And I look up at him. I said, you told my husband the odds are not in his favor. He said, I said, don't you ever say that again to him. At Duke, there is hope, and we are having hope. Yeah. And wherever anybody is going for treatment, I want them to feel like there is hope. If you're telling him the odds are in his favor, what's the point then? Exactly. I said, don't you ever. And again, people, if you don't know me, I'm not a big girl. Speak that way to my husband again. And all 6'5" of this man looked down at me and said, okay, Holly, I'm so sorry. I'm so sorry. Okay. And he didn't. So I want to go into at Duke, there is hope, right? Because some people feel like it's false hope. And, when their doctors tell them this, and then it turns out that the person doesn't live very long, or the journey is really difficult, which it can be. So can we talk? I'd love to talk about this with you. Maybe we talk about at Duke, there is hope, and what that means for you and how you carry the hope, well, knowing what the outcome, but we don't know for sure, right? How long the outcome will take to get to be.
Exactly. No, it's a great question. And in fact, that's something, right, that I think about all the time, and our approach, in fact, with all our patients as the first visit, right? At Duke, there is hope. And you're absolutely right? A patient, a family, and I'm sorry it happened to you, and unfortunately it happened, right? It happens all the time, right? This week, another family was telling me, right? They told me, right, you would lie to me and you'll give me false hope. And I have to disagree with how I disagree with that is here. What I tell patient is what it is for me at Duke, there is hope. And that's the reason why I stayed at Duke, right? So the university, one thing we didn't talk about, right? The university that where I trained in Canada paid for my fellowship at Duke. They sent me for a 2-year training at Duke. I was supposed to go back. They paid for me to be here. I didn't go back, as you can see, right? I stayed at Duke. And the reason was because of that, this mentality that for me resonated with me, which is, so what is for me at Duke, there is hope. And how I tell the patient, how I insert that, or how I introduce that to the patient is really, before me, everybody you have met so far told you that this is bad, right? And I know you have looked on the internet and you know it is bad, right? My job is not to tell you it is bad. We know it, right? But if I was just to look at you and say, oh, Ollie, sorry, this is bad, Ollie, I'm sorry, right? I could not do my job, right? Because I would be so depressed. So my job is to say, what are we going to do about it? And that's how I approach it. At Duke, there is hope for me to be able to continue to help my patients, their families, right? For me to be able to keep doing clinical trial every time, even if another drug fails, right? And all this time and investment is really the fact that the question is, what are we going to do about it? So we might not have the cure, but I can give you more time. I can reach the goals you want to see when your child graduate from high school or get married, right? You want to make this cruise, right? What are we going to do to control the seizure, to try to control the tumor for as long as possible, to adjust the treatment, right? To bring us to these new goals and spend time together as a family. So that's how I see at Dude, there's hope. My job is not to say, oh no. My job is, I tell the patient, that's exactly what I'll tell them. Everybody tells you this is bad. My job is to be your cheerleader, to make this very difficult time in your life, in the life of your family, as easy as possible. I cannot remove the pain, I cannot remove the grief, but I cannot try to at least not make it worse. Right? Does that make sense?
Yes, it makes perfect sense, and it's beautiful. Because I believe that's why the podcast is created space for grief and hope. Grief is hard. Having that hope, I created this acronym for hope. I've seen acronyms for it. Hold on, pain ends. I don't love that one. But hold on, persevere every day. Why not? I always say, why not have hope? When I hear people whose loved ones have died from this disease and they say, they shouldn't have given us hope. I said, but why not? I'd rather have hope, whether it's real or not. It's real for me.
Exactly.
I'd rather have the hope as I go through this, and I call it a journey. Some people don't like that word, but that's what I call it. I'd rather have the hope for that than sit there in the abyss of the fear, which was still there too anyway. The grief and the fear and all that is still mixed in that bucket of hope. But if the hope can be that much bigger, that you can get through each day with that hope. Like even when Stephen, we knew there was nothing more we could do, every morning he'd wake up, and I tell people whose loved ones are dying, every morning he would wake up, Annick, and I would say, yay, you're here.
Yeah.
Yay. Great. Another day of hope. Why not? What's the worst that can happen if you have hope?
Exactly.
You're already blindsided. And that's my personal opinion, my personal way of living, my personal philosophy. So the hope piece, and now let's get into, and again, I want your personal emotional experiences. When you walk in to an exam room, right, and you see patient A, you just read the scan, it is stable, things are looking good, they're coming to you for some time, you've already created this rapport and relationship. with them and hopefully the care partner, because that's the one who's messaging you all the time, not the patient typically. So when you go in to share the good news, the better news, you pull it up and the cavity's still there and, it's not filled up with tumor. And, I remember all of this, gosh, like it was yesterday. What is that feeling for you when you walk into that room to let them know that all looks well right now?
Yeah. I mean, this amazing energy, right? Absolutely. So my patients make fun of me. I have no poker face, right? You can read all my emotions. So my patients say, just when you open the door, we know what's coming, right? We know what's coming when just you open the door. And the answer is, right, it is, as you said, like this reprieve because, right, I mean, the vast majority of my patient, right, I mostly see glioblastoma patient, I would say 90% of my patient. And bringing good news is like, right?
Even for you, right? It is for the patient and it is, for their care partner, their caregiver. But even and this is what I want my listeners and viewers to see, that you go,
yes. Yes. It's like this big, and my patients know it, right? I will tell them, right? Because we talk a lot about anxiety, right? The week before the MRI, like everybody gets worried. And I tell them, like every MRI I open, right? I make a little prayer. Like I'm like, please be good news, right? Because we really do get at that. Like I know, right? The patient, their loved one, their children, the grandchildren, right? And I want to bring, and I know how hard they work on their physical therapy, their occupational therapy, right? Or speech therapy, how dedicated they are or what their goals are. And so every patient, every time I look at the MRI, is like this stress, this anxiety, right? And then the relief. And it's like, yay, as you said, like you were telling, right, Stephen, to your husband, like, yay, today is a good day. Like, we got this, right? And I always tell I always tell my patient, then our job today, right? Like, let people say, she'll lie to you, she'll give you false hope. No. What I tell my patient is, today we have a good scan. This looks great. What is our homework? Our homework is to continue what we're doing and work on keeping the rest of our body healthy, right? If we have to work on the balance, the gait, if we have to work on seizure management, now is the time to do it. So we are prepared that if someday we have bad news, we can say, let's go for it. We handle everything else, and I can think about the next treatment. Not, my tumor is worse, I need to talk about a new chemotherapy or immunotherapy. And on top of that, I didn't get off the couch for 3 months and so I've lost all my muscles, right? Or I cannot eat, or, right? So when we have good news, it is not we sit and we do nothing. It is more, okay, what can I work on improving to maximize that if someday I need the next treatment, right? I would be ready for it. How to optimize.
So now let's go to the other end.
Yeah.
Progression, crossed over the other side, which is what happened with Stephen.
Yeah.
And most people, unfortunately. Now there's really nothing more. Like there's no other treatments that are going to keep this person on this earth.
Yeah.
Now you've got to go give that news. And what are the emotions for you in that news? How are you present for them when they hear this? Because if you're in the exam room, we knew from the oncologist in Charlotte when Wendy had said, it's crossed over the other side, because when Dave said, you don't need to come all the way to Duke for me to read let's just see what it looks like in Charlotte and then we'll go from there.
Yeah.
And then Dave called, so, but to be in the exam room and walk in and say, this is where we are. We're gonna, I recommend you call in hospice care. What is that like for you as the doctor. And this is what I want everybody to see and understand, that this is not just another day at the office. This is far from another day at the office. So if you're comfortable, share what that experience, and you've done it many times, and you've done it with people I know, right? You've done it with friends of mine and clients of mine, family members.
Yeah. I mean, I think that it's personally, right? For me, what works, it's very emotional, right? My patient knows it, that I'm sad. My patient, right, know that my heart is broken, right? They know it. From my standpoint, right, it's really hard because I don't want to make it about me, right? Like it's them, but how I feel personally is, right, every time is like, how did I let them down? What could I, that's when the doubt comes. What could I have done differently? Right? Even knowing that we don't have a cure for GBM, right? We don't. So internally, right, what I always ask myself is, what could I have done differently? In the room with the patient and the family, right, is really, in fact, reflecting this. Here is everything we have done. Here is how this awful tumor is behaving right now. Not because we didn't try, not because we didn't put the effort. But at this point, right, often when we stop treatment, it's could we try something else? Yes, right? But when we don't do anything else, most of the time is really because the body is too tired. The neurologic function, right? In brain tumor, it's more, right? The brain will not recover from this, right? When the tumor has crossed to the other side, right? Like what I have in Stephen, you don't rebuild brain, right? And it's really talking about dysfunction has been lost. I cannot rebuild brain connection. And there's nothing that will improve the quality of life. And I think it's just explaining that. It's not that we're giving up on them. Or I'm giving up on them. It's really explaining that the degree of injury in the brain is such that the autonomy, the independence won't be there. I'll be honest with you, Holly. I'm not sure how to answer your question because despite the fact that I've done it multiple times, it's never easy, right? Maybe the only thing that has improved, if I think about it, is the words that I know a little bit better, that I feel people will understand, right? And to be honest with you, right, the vast majority of my patients, they're way ahead of us, way ahead of me, their loved one, their spouse, right? The patients, when the vast majority of them are, I knew, right? Really,
I knew.
yeah, I knew. Who is it the hardest for is the family, the loved one. I think it is really hard for us. I don't say it's the hardest because the family and the loved one, right, is the hardest for all of you that lives that. But as a physician, it's also living with this grief that we were not able to remove that pain from our patient. The grief that we cannot remove that pain from their loved one. their family, right?
I see it's emotional for you just talking about it.
Yeah, I mean, and it's very like I can see myself in the room. Like the patients know it, right? We hug, I thank them, right, for letting me take care of them. I thank them for trusting me to be part of their journey. It's hard. It's really hard.
And it's interesting in medical people and people that I talk to who are caregivers, caretakers, they talk about when if it's a resident, whether, they work in, a senior living community, whatever it is, hospitals. And we talk about that. They feel like, who are they to grieve when it wasn't their family member, even though it's someone they cared for. And they feel this sense of, I don't want to use the word guilt because I don't love that word, but there is something that they experience that, who am I? Who am I to have the right to grieve this person when it wasn't my family member? It was just someone I was caring for. But you create this energetic exchange with people and these relationships and these deep connections, whether it's, some you have for several years, you have long-term survivors, and sometimes it's just 6 months, but you still have this energetic exchange in this relationship. And so what I say is the intensity for you may be different than the partner, right? Than the spouse or the child, or the parent or siblings or whomever. And the best friends. But it's still your grief. And you still get to have it. And you still get to feel it. Because that energetic exchange is now coming to an end in some way. Like that connection. And part of that connection is seeing this person either once a month or every 6 weeks or every 8 weeks, or if they're doing really well, every 3 months, whatever it is. So, but you're used to seeing them for a certain amount of time. You're used to seeing the person who comes with them. So we'll say like Stephen and me, you're used to seeing someone's husband and then their wife comes with them, or vice versa. And you create this whole relationship. And then all of a sudden, that person now is on hospice care. You're not going to see them anymore. You may be in touch a little bit, and then you find out they die, and Duke does this beautiful thing and sending a beautiful card, and it's really lovely. And I love that. And it happened for us. But that's it. It's done.
Yeah.
It's done. You never see them again. Unless the care partner comes to visit, maybe they live close by and they want to come visit, or they want to bring a gift, or whatever that is. But that relationship, all of a sudden, what you have been building from the first day you walked into the exam room to talk to them and share with them what the plan is. And this is, because at Duke there was hope. Like, this is what we're going to do for you. Yeah. And now it's cut off completely. So there's a lot of grief is change. And sometimes there is good change, but this is not a good change. So I say, give yourselves, your medical community, permission to grieve. Of course you're grieving. Is it the same intensity as my grief? No, but that doesn't mean you're not. We all grieve at 100%.
Yeah.
So that you experience that as part of your humanness. And the huge change now that's come into your world. Now you're just don't even see these people anymore. And you wonder, how are they doing? And how is so? I mean, I email Dave every now and then because I send referrals and stuff like that to him, or just whatever. I just check in, so he sort of knows what I'm doing. But you don't know. Like, if you don't know, you don't know how someone's doing, and you wonder. And it's a huge cutoff. All of a sudden, boom, done.
Yeah.
So of course you're grieving. So give yourself permission. This I don't get to. It's not about me. You said it's not about me. It's about them. Well, yeah, it is about them, absolutely, but it's also about you. Because you're a person with human emotions.
Thank you.
Yeah.
Thank you. Thank you for.
Thank you.
And you are absolutely right, that losing, losing this ability to see them regularly, right? See the family regularly is a big loss, is a big grief. We're very lucky. One thing I don't know if you know, so you probably do. So we have one of probably my favorite events at the Brain Tumor Center at Duke, right? Is the Angel Among Us.
Yeah, we used to go to it. Yep.
Yeah, the 5K run and fun walk. So it's most of the time the last Saturday of April. And a lot. Like I have families, right? I've been here for a very long time. And you are absolutely right, right? I have families that their loved one died 15 years ago and they still come.
Mhm.
And so at this year, right, I think we had over 4,000 people that came. And having this hug once a year, right, of knowing that they still believe in us, that it was still important for them to come and recognize and celebrate their loved one. It's such a powerful event to have that.
It's a great event.
Yeah.
If anybody is near that area in the Raleigh-Durham, Chapel Hill area, it's a beautiful event. I haven't gone in a long time, but it is a beautiful, very powerful event. And then I know that, Rebecca Feinglass is starting the Grief Center.
Yeah.
And I know it also is going to include team members. It's not just for people who have lost a loved one to a brain tumor, but also for the team members, which is going to be a great thing when that, takes off. It'll be a great thing for all of you.
Yeah. It's
Yeah.
starting, or we have our first event next Wednesday.
Right.
So we're really excited about that.
She's
Yes.
phenomenal. What she's doing is phenomenal. So I know we have to be ending. I know we've gone over time, but that's not unusual for me because I always want to get the meat of stuff. So I'm going to ask you one more question. What do you wish people knew about grief in the medical community?
Mm. I mean, that it's real, right? We do care deeply. If you only knew, right, how much our team cares in our workroom, right? So when, in the clinic, we have our space, we're all sit together and we discuss the patient and come up with the plan so we can come up as a team, right? When we meet with the patient and the family, that's where we process a lot of our emotion together. So I would just say, please don't think we truly believe. When I tell my patient that my team, right, our team, they see themselves as your cheerleader, right, against everybody else that tells us brain tumor is bad. And we're like, but it's still worth it. They still deserve love, care, listening, space.
Beautiful. Thank you. Thank you for that response. Thank you for joining me today, my friend. This has been really meaningful for me, and I know that people watching and listening are going to find so much meaning in all the things you shared and getting a really clear understanding that the medical profession, they're humans too, right? And you have these human emotions, and it's not like this, okay, next, because it does feel that way. So next, especially the Brain Tumor Center, it's like, oh my gosh. And it's not that way. It may look that way, but it's not that way. Your hearts are full and your hearts hurt just as much. And so I thank you for joining. I'm going to give you a big virtual hug so everybody can see.
Big hug to you too.
Thank you for joining. Thank you all for watching and listening. Our second episode on YouTube. Please share this podcast with those you know, review, and subscribe to Creating Space for Grief and Hope, whether you're doing it audio through all the audio platforms or on YouTube. And I thank you all. And next month, we will have another guest and look forward to seeing you all then. Thanks so much, everybody. Big hugs and kisses.